Go live.
Good afternoon, doctors. On behalf of Heathrow Healthcare, I, Dr. Prashant, welcome you to this webinar on influenza and its prevention. Dr. Heathrow Healthcare, we will market products in different therapy areas like in respiratory, gynecology, orthopedics. We have very strong R&D support and we have developed many unique formulations keeping patient benefit in mind. We have developed patches of NSAIDs, we have developed patches for antipsychotic drugs. We have 30 years of excellence and 300 plus products, presence in more than 125 countries. We have Asia's largest manufacturing at SEZ Visakhapatnam, Andhra Pradesh. During COVID times, we have marketed Favipiravir, Remdesivir, and we have won award of Pharma Excellence August 20 for COVID drug. We market Oseltamivir, and to share their experience on influenza and its management, today we have got Dr. Swati Shruti and Dr. Sainath Powar with us. Madam Dr. Swati Shruti is MBBS DCH MD Pediatrics with Diploma in Child Adolescent Disease and Child Nutrition from Boston, USA. Director and founder at Chirayu Hospital, Satara. Consulting pediatricians and neonatologists since 1996 at Dattakashi Hospital, Satara. Life member of several associations like IMA,
कुठे
Indian,
जाणार आहे
कुठे जाणार आहे?
हो मणिराजुरी
हा मग
Indian Association of Pediatrics, National Neonatologist Forum, India, Infectious Disease of Pediatrics. Madam has served, arranged, and participated in several camps in and around Satara and Lok Biradari Prakalpa, Kasa with Dr. Prakash Amte and at Search, Dr. Abhay Banga. Welcome, madam. Welcome to this webinar. The next speaker for today evening is Dr. Sainath Powar. Sir is MBBS, DCH, FCPS, Fellow in Allergy and Asthma from University Hospital at Leicester, UK, Certified Pediatric Bronchoscopist by AAPS at IIP, Consulting Pediatrician and Pediatric Pulmonologist, Consulting Allergy and Asthma Specialist, President Kolhapur Academy of Pediatrics 2024, National Trainer for several programs like NTAP, IIP Action Plan, Pulmostar IIP Module, IIP REAP Module, Executive Board Member for Maharashtra Respiratory Chapter of IIP. Welcome, Dr. Sainath Powar, and over to you for further deliberations. Thank you, sir.
So thank you, sir, for the kind introduction. And first of all, I would like to thank the Hetero team for giving me this opportunity and to present this topic. So basically, nowadays already, as I said, nowadays also in Kolhapur, there is a lot of rains are going on. So this flu season is on only. So generally, it is we can say that it is in the generally it is in the we can say that it is in rainy season, but nowadays rainy season is always there. So in December also we are worried that whether will going to get rains. So basically flu has become a very common thing. So today we are going to discuss the topic empiric use of oseltamivir in flu management. So what are the contents? So healthcare challenges in monsoon and their diagnosis, influenza and its complications, clinical evidence of oseltamivir, guidelines recommendation for empiric use of oseltamivir. So what are the key facts? So basically, according to WHO website, there are around billions of cases of seasonal influenza annually, including 3 to 5 million cases of severe illness. It causes 2,90,000 to 6,50,000 respiratory deaths annually. This is from WHO side actually. And 99% of death in children are under 5 years of age with influenza-related lower respiratory tract infection. These are in developing countries. And symptoms begins 1 to 4 days after infection and usually lasts around a week. So basically, healthcare related challenges in monsoon. So basically, in monsoon, what do we get? So it is an influenza-like illness. It may be H1N1. It may be sometimes SARI, severe acute respiratory illness, and COVID-19. So these are the 4 illnesses which you do get in monsoon-like seasons. So basically, dynamics of the occurrence of the influenza in relation to the seasonal variation, and this study was done in Chennai, Tamil Nadu. So it was a 7 years cumulative study. So basically, it was done Department of Virology in 2019 in King Institute of Preventive Medicine and Research, and almost 3 lakhs 36,670 specimens were subjected to influenza analysis, and the influenza positivity started. So they have inferred that influenza positivity started with the onset of monsoon and peaked during post-monsoon month. So this is a overall incidence of overview of the influenza in India. And as the you are seeing that as the days are going, like uh, previously it used to have lesser number of cases, but now as the year is progressing, the number of cases are increasing. So this is the blue one. These are the basically cases of influenza, and these are death this due to influenza. So this blue is 2015. It was around 4,259 reported cases. In you can say 2018, it was 1,500 to 15,266, and now in 2019, it was 28,798 cases. And accordingly, the deaths were like uh, in 2015 it is 299, in 2018 1128, and 2019 1218. So as you say that ki, as the years are progressing, the cases and death both are increasing. So what are the common symptoms of flu? So basically, you will have fever. It may be associated with chills. Sometimes it may not be associated. There will be body ache. There will be headache. There will be cough, cold, sore throat, tiredness, feeling down actually, and diarrhea and vomiting may be there. So let's discuss with few cases. So before discussing theory, we will discuss few cases. So this is a 2 years old female child admitted with cough since last 5 days. It was dry cough, cold since 4 days, which was running nose, fever since last 3 days, which was high grade intermittent. And on examination, child was having thoda sa tachycardia, respiratory rate was 35, and tachypnea was also there. And on examination, respiratory examination, there was bilateral occasional Krebs and bronchi. And the provisional diagnosis of this patient was our LRTI. So we had done investigation. CBC was almost normal. There was lymphocytosis, uh, platelet was normal, CRP was little high, and this was the X-ray. So X-ray, you can see here that X-ray is showing some right side hilar haziness. There is some infiltration on the left side also, and in mid zone there is some infiltration. So this was the X-ray which we had done. So which has shown that there is some lower respiratory tract infection in this patient, and it is with cough, cold, fever. So he was started on IV antibiotics. We have given him nebulizer with levosalbutamol. So after starting this treatment, his tachypnea, respiratory distress little reduced. He become little more respiratory signs wise he was better. But on day 3 of the admission, the child has become drowsy now. And the child was drowsy, sick look, and child was not accepting fields. So this was not a good thing for us. So then we thought there is something which is going wrong, and in spite of starting antibiotics, X-ray is not bad. CBC CRP is also not showing anything great. So whether we are dealing with some viral infection, so we have sent the swab of H1N1, that is flu swab was sent, and which came positive. So basically after sending the swab, we started this patient on oseltamivir, and within next 48 hours, his patient's sensorium also improved, patient respiratory rate also become normal, fever also subsided, and overall patient has improved. So this case has given us some insights that key whenever you are feeling you are dealing with respiratory case, your investigations are not directing towards bacterial infection, and the child is becoming drowsy, sick look, or maybe this drowsiness means you can say that sensorium is deteriorating. This was we considered as a red flag in this patient, and then we went ahead with diagnosis of H1N1. So this was our first case. So whenever we are treating patient, we always see whether this is viral, whether this is bacterial. If your patient is coming to you with some respiratory symptoms, and how do you differentiate these patients? So basically, if it is viral, then it is a acute onset, uh, more gradual than bacterial, and there may be some other patient, other means family members may be having similar symptoms. In bacterial, there is a generally fever is high grade, and to start with, it is generally high grade. And in viral, if cough is there, this is a predominant symptom. And in bacterial, sometimes maybe absent also. Sometimes in viral, lymphadenopathy is less common, but you can get in bacterial tender cervical lymphadenopathy. You can see because of the associated throat infection or tonsil infections. Associated symptoms like rhinorrhea, exanthema, hoarseness of voice, more frequent in viral, diarrhea, conjunctivitis, multisystem affection may be there in viral infections. And generally, bacterial infections are well localized, so less coryza nasal symptoms. Local examination, you can see just pharyngeal redness, but in bacterial infection, you may get thick, exudate, purulent, patchy, tonsil-like, or redness of the throat. So this was our differential between viral and bacterial. Now we'll see the another case. He is a bigger child. Initially we have seen a child which is 2 years old. Now we are seeing a child who is a 14 years old.
Excuse me, Dr. Pawar. In
Ah,
first kit, I would like to add something more.
yes, madam.
In case of viral infection, the child usually is alert and playful. Otherwise,
Yes,
in bacterial infection, the child is dull and looks toxic.
toxic.
So
Yeah, but
that is the main
uh,
feature. You can
but in
easily differentiate on OPD basis or on the examination.
yes, madam. Yes, madam. But here the in this case or generally, if we see a viral patient, we have taken this patient as viral only.
Yes.
But as he's becoming drowsy, then it is more pointing towards H1N1.
Yes, yes. That is
Yes,
differentiating point. Yes,
yeah,
very
yes, ma'am.
rightly you differentiated. Yes.
Yes. So now we are coming with another patient who is a 14 years old boy with there was no underlying other comorbidity condition, and he was referred to our hospital with complaints of low grade fever, sore throat, and myalgia and sore throat for 7 days. There is no history of breathlessness, vomiting, and diarrhea. He has received antibiotic in previous hospital with ceftriaxone and piperacillin tazobactam, but there was no improvement. So basically, on examination, pulse of 110, BP of 110 by 72, and temperature of 100 degree centigrade. On respiratory examination, there was bronchial breathing. There was bilateral coarse crepitations in the inframammillary area. Midzone. So basically, midzone interstitial infiltrate was seen on X-ray chest. Nasopharyngeal swab was taken because he was already referred with respiratory cases. There was a flu season already going on. So we had done a swab for this patient and which came positive for H1N1. CRP in this patient was 10, so which was borderline. Rest other system were normal. Laboratory evaluations revealed a normal hemogram along with the leukocyte count. Liver function test was normal. And this was the X-ray which has shown bilateral infiltration actually. So basically, here patient was referred here for a second as a tertiary care center. He was having not responded to antibiotics, two better antibiotics. First was ceftriaxone, second was piperacillin tazobactam, but there was no improvement. The X-ray has shown bilateral haziness. Relatively, child was stable. This child was not drowsy because generally drowsiness is seen in the smaller babies. So this child was, in spite of this X-ray picture, he was relatively stable.
असं
So
चालू
we
काय
had done, so we had done a swab and which was positive. So we have started him on oseltamivir 75 milligram BID for 5 days, and he was given paracetamol, hydration, and other things, other supportive management. And patient showed marked improvement in his symptoms. And slowly the X-ray also becomes slowly normal. After 50 days, X-ray was almost normal. So, madam, do you want to add anything in this case, patient? Madam, we are not, your voice is not heard.
नहीं, appropriate treatment, hydration. Just ask patient to mention continue hydration. Hydration
Yes,
will clear everything.
yes. Okay, madam. Yes. So these are the basically cases. Now we will discuss some theory about influenza. So basically, influenza, one of the most common infectious diseases caused by influenza virus. It is highly contagious airborne disease that occurs in seasonal epidemics and manifests as an acute febrile illness. And basically, depending on the surface proteins of this virus, that is hemagglutinin and neuraminidase. So these are basically these proteins go into changes every day or every year, and that's why there is a drift of this year. So generally they are labeled on this H and N. So H1N1 is our is our this swine flu, H2N2, H3N3. So depending on these two surface proteins, they are basically classified, and basically there is a uh, change in maybe 1 to 2 years. These proteins do changes, and that's why we have to change the flu vaccine every 1 or 2 yearly. That is, every seasonal we can change. So it can cause mild to severe illness. Serious outcomes of flu infection can result in hospitalization or sometimes deaths also. So which are the influenza viruses? So this is the first is influenza A virus. So as we discussed that H and N antigenic variations, they are divided into H1N1, H2N3 or something. So sometimes they will cause epidemics and sometimes they can cause pandemics also if there is a major antigenic variation. So influenza B virus is infects only human, it causes local epidemics. Influenza C virus, it infects human and swine. And influenza type C infection generally cause mild respiratory illness and not thought of any epidemics. So currently circulating viruses are like H1N1 and H3N2 influenza viruses. So transmission, as it is spread through the droplets, and it is generally it can go to 6 feet away from the patient. So basically, it is transmitted to droplets made when patient cough, sneeze, or talk. These droplets can land into the mouth or nose of the people who are in contact with those patients, and they can go to the lungs. So people should stay away from the flu affected person, and we should advise them that if any patient is not well, so they should stay at home, because in children also, if they go to the school, they will transmit this virus to many other children, and then that goes on increasing only. And also hand washing is very important in this any flu, yeah, because generally they can transmit through fomites also. So hand washing is very important. So children may pass the virus for longer days, that is for almost 7 days. So whenever we are seeing this influenza-like symptoms, then as we have already discussed, these are the 4 diseases: influenza-like illness, H1N1, SARI, severe acute respiratory illness, and COVID-19. So generally, if we see to how to differentiate it, so this initial symptoms like fever, myalgia, cough, decreased energy, sore throat, this will be there in all of those symptoms. Breathlessness will be less in the influenza-like symptoms. Other three can have breathlessness also. The loss of smell, loss of taste was a phenomena of COVID-19. So it is not present in other three viruses. Diarrhea generally seen with COVID-19, but may be seen in H1N1 also. And headache, it may or may not be there. So it is not very clear on that. So headache is a common symptom which may be there or may not be there. So again, emergency warning signs of flu sickness. So in children's, fast breathing like tachypnea, cyanosis, not accepting fluids, not waking up. That is again, as we discussed, patient is becoming drowsy or sensorium is deteriorating. That is a red flag sign in a patient with respiratory symptoms. In smaller children, there will be irritability, and they doesn't want to means go with mix with anything, and they doesn't want to be held. So sometimes flu-like symptoms improve, but return with fever and worse cough. So that is also a emergency sign that should be looked after. And fever with rash is again we have to keep a watch. So in addition to sign about get a medical help right away for the infant who has any of these signs, as we have discussed, not able to eat, he has tachypnea or breathing problem, it has means there is no tear, that is he is so dehydrated he is not producing tears while crying, and significantly fever weight diapers means basically reduced urine output. So these are the signs where if infant is showing these signs, you have to rush to a doctor. So complications of flu. So what are the complications? First is pneumonia, second is bronchitis, then ear infection, then worsening of existing, like if the child has got asthma, then or allergies, it can worsen, then acute respiratory distress syndrome, and sometimes death is also possible. So again, who is at more risk for flu? So basically, certain conditions, if they are there, we have to be more worried about flu. The first important thing is asthma allergy. Second thing is, if any chronic disease like liver disease, kidney disease, neurological disease, chronic disease will reduce their immunity and they will have more problems with flu. Juvenile diabetes is one thing that they may have more problems with flu. Any patient who is immunocompromised, maybe because of the HIV, AIDS, cancer, immunosuppressive medication like nephrotic syndrome on steroids, they may have more problems with flu like flu. Sickle cell disease can have more like problems with flu. Obesity is one of the high risk factor. And if the child is in daycare center, so because of multiple exposure of multiple viruses, they can have the repeated symptom. So now we are coming to management of influenza. So always supportive management come first, bed rest, increase fluid intake as madam has advised, you should take more fluid. If the child is not able to take oral fluid, we may give sometimes IV fluid also. So he has to maintain his hydration, that is very important. Subcompression, generally we do not use, but if the very irritating cough, dry hacking cough, use cough suppression for very small time. Antipyretic SOS, NSAIDs may be better to avoid. Paracetamol is the best drug we can use in these patients. Most of the patients with influenza recover in 3 days, but however, sometimes they have malaise for maybe 1 or 2 weeks. And sometimes severe cases may require IV fluids and other supportive management. So treatment with antiviral drug. Now we are coming to antiviral drug. So neuraminidase inhibitors. So it blocks the viral neuraminidase enzyme, which is critical in the releasing virus from the infected host cells. So these drugs are active against influenza A and B, and the examples of these inhibitors are oseltamivir and zanamivir. The another group comes at adamantane that is M2 ion channel blocker. They interfere with hydrogen ion channel activity of the influenza virus, thus blocking its entry into the host cells. So it is active only against influenza A virus. And the examples are amantadine and rimantadine. And out of which most commonly drug, as you know that this is oseltamivir, because we most commonly used drug is oseltamivir. So antiviral therapy with oseltamivir. So it is a potent and selective inhibitor of the neuraminidase enzyme of the influenza A and B virus. So it is a prodrug which converted to active form, which is called as oseltamivir carboxylase in the liver. It inhibits influenza virus replication and its pathogenicity. So it will not allow the virus to replicate, and so the number of viruses are reduced, and it will contain down the disease. It prevents further spread of the infection also, and it is effective against all strains of influenza A and B, including the avian H5N1, swine origin H1N1 and H9N2 strains. So basically, this will act here, and these are the neuraminidase inhibitors which will block the sites, and so no virion release will be there, and it will halt the viral replication. So it was the first oral neuraminidase inhibitor, and oseltamivir is approved for more than 100 million. It is CDC, FDA, and American Academy of Pediatrics has approved this oseltamivir for the pediatric use also. And these are the doses and recommendation of the oseltamivir treatment. So adult 75 milligram capsule twice daily. This is for treatment. And according to age in children less than 15, you give 60 milligram per day divided into 2 doses. In 15 to 23 kg, 90 milligram per day divided into 2 doses. In 23 to 40, 120 milligram per day divided into 2 doses. And more than 40, you give the adult dose actually. And if you want to give chemoprophylaxis to the patient in the contact, then it is 30 milligram. For less than 15 kg, it is 30 milligram once daily. For 15 to 23, it is 45 milligram once daily. 23 to 40, it is 60 milligram once daily. And more than 40, it is 75 milligram once daily. So the recommendation duration for post-exposure prophylaxis is 10 days. And the recommended duration of the community outbreak, that is seasonal pre-exposure prophylaxis up to 6 weeks. And if it is the child is immunocompromised, you can do it for 12 weeks. So one more thing is very important. If you suspect H1N1 or any influenza, then you start the treatment very early. If you start the oseltamivir before 48 hours of the onset of the symptom, it will work the best. But in another way, if you are late and if you are still suspecting H1N1, do not stop it. Do not avoid to give it because it is late. Even if it is late, it will act, but it is best act within 48 hours. So what is the benefit of empiric use of early use of oseltamivir? So oseltamivir treatment in the treatment of influenza-like illnesses, it reduces the antibiotic use and hospitalization. So there was one study which was shown that in the patient of influenza, if you use the oseltamivir, then it will reduce antibiotic use, then it will reduce the hospitalization also. It will definitely, oseltamivir will reduce occurrence and severity of the pneumonia due to the H1N1 by early oseltamivir administration. So there was a study done on 442 patients, so the mean time of oseltamivir administration was 5 days, and these subjects were divided into 4 groups depending on the time of oseltamivir admission, when it was given. When it is given before 2 days, then 3 to 7 days, 8 to 14 days, and more after 14 days. So basically, both the probability and severity of the pneumonia and the probability of severe pneumonia increases gradually with the time from symptoms onset to the oseltamivir administration. So as you administer oseltamivir late, the chances of getting severe pneumonia are more. Earlier initiation of the oseltamivir administration after symptom onset significantly reduce the occurrence and severity of the pneumonia. So again, same thing, if you given early, the pneumonia will be less. And even when administered 48 hours after symptom onset, oseltamivir has shown considerable potential for reducing pneumonia. The patient with shorter time of the oseltamivir admission were discharged earlier from the hospital. So those who are started early, they are discharged early. So there is one study which has shown that oseltamivir along with azithromycin, whether to use or not to use. So that study has shown that if you use azithromycin, so if azithromycin and oseltamivir, if you use combined treatment, so it has got a significant reduction in the incidence of the secondary bacterial infection, and this patient required less respiratory support. So basically, this is the incidence of the secondary bacterial infection. This is the group with both like oseltamivir and azithromycin, and this is the group with only oseltamivir. So what are the WHO recommendations? So empiric treatment is recommended. Treatment should be started as soon as possible and as soon as you suspected that it is an influenza-like virus. And laboratory confirmation of the influenza virus is not necessary. You can, if you are strongly suspecting clinically, you can start, or you can send the swab and then you can start the treatment. So negative laboratory test for H1N1 does not exclude the diagnosis in all the patients. Therefore, you can still use the oseltamivir. In higher risk individual that we have already discussed, if those patients are exposed to the influenza, you can start the presumptive treatment of oseltamivir. So give empiric antimicrobials to treat the likely pathogen causing SARI. Empiric antibiotic treatment should be based on the clinical diagnosis, community acquired pneumonia, healthcare associated pneumonia. So if the infection were acquired in healthcare setting or sepsis, the empirical therapy should include neuraminidase inhibitors for the treatment of influenza when there is local circulation or other risk factors, including travel history or exposure to the animal influenza virus. So this is guidelines given by Ministry of Health, Family Welfare of Government of India. So overall summary is like proper diagnosis can and early treatment can prevent the flu complication. Empirical use of oseltamivir in if you are clinically thinking it lowers the respiratory tract complication, hospitalization, and antibiotic use. WHO, American Thoracic Society, and MOHFW recommends empiric use of oseltamivir. So thank you very much.
Thank you,
Madam,
sir.
do you want to add anything?
Yeah, madam, would you like to add anything?
What is your clinical experience in like flu-like patients or something?
This presentation was excellent. Thank you for the hetero team for giving this opportunity to both of us. I think I think that people are a bit reluctant to start with antiviral, whatever may be the reason. But I will tell everyone that this is now in our OPD practice, we are facing so many flu patients, viral flu patients. So, and we are observing that for over last couple of years, the presentation of viral URTI is changing. This year it was a bit different, so it was a tricky. But still, if you timely intervene and timely start antiviral drugs, this will prevent the viral pneumonia, which may be dreadful to babies which we are treating. The
Thank you, madam.
presentation was very nice.
Yes, sir. Really, the insights were very good. The cases were very good. I mean, it brought out really insights of your
We are
views.
just keeping a simple case. This is a routine
Correct,
day-to-day
correct.
OPD patient
Correct,
actually.
correct.
And I
Yes.
have seen similar 3-4 patients in my IPD also, similar.
Absolutely,
Same age,
absolutely.
1-2 years around, those have become drowsy. Starting oseltamivir within next 24 to 48 hour patient has improved.
Came
All
down.
the reports were normal.
Very good.
So this
And
is a
especially in
common scenario that we are seeing actually.
And in children, especially when they are not able to tell what happens, I mean, it's a
In
very
infant also we have to be more
Yes,
aggressive.
yes,
Means
yes,
1 to 3 years. 1 to 2 years is a more important
and
age group because
they have very short reserve. Immediately they go downhill.
yes. So if you
Wonderful.
don't treat it with proper
Correct,
care, then they
correct,
may
correct.
go into on ventilator or something
Absolutely.
with
Yes,
some
yes.
respiratory complication actually.
So
And in
thank-
most of the cases, family history is usually there, and we should ask the family
Right.
members to use mask. Once, even if single symptom is seen in the family, ask the family members to use mask. That will reduce the transmission of viruses.
Yes, ma'am. Yes.
So thank you, Dr. Powar. Thank you, madam. I thank all the participating doctors who took time from their busy schedule and could attend this program. Thank you, marketing team Hitro, for conceptualizing and organizing this webinar. It gave us a lot of insights into the actual use of oseltamivir. And last but not the least, the field team of Hitro and IT team of Hitro, thank you very much for your participation. Thank you.
Thank you, sir.
Signing
Thank you,
off.
madam.
I wish you a very
Thank you.
pleasant
Thank you, sir.
evening. Thank you.
Yes, thank you.